ना हो
हमें दुनिया की सबसे बड़ी जन कल्याणकारी योजना आज लोगों को आजादी के संसार द्वारा करोड़
Who are answering today?
Sir, me, Dr. Rupam from Kerala Institute of Medical Science, Trivandrum.
Okay, you are Rupam from Trivandrum.
Yeah, yes, sir.
And yes, who else is answering? Rupam, you know who else is answering?
Sorry, sir, I don't know about that.
Progress.
एम्स की संख्या 3 गुनी, स्वरोजगार स्टार्टअप में ऐतिहासिक बढ़ोतरी हुई। हमने भारत को दुनिया का दूसरा सबसे बड़ा मोबाइल मैन्युफैक्चर बनाया। अब इलेक्ट्रॉनिक्स, सेमीकंडक्टर और ऐसे नए सेक्टर्स में और हमने
नको ग मला ते मला आता त्या मी आग होते
हम अपने युवाओं को शिक्षा, रोजगार, स्वरोजगार हर क्षेत्र में किसानों के लिए बीज से बाजार तक आधुनिक नीतियों को बनाने का काम और प्राथमिकता पर होगा। दलहन से लेकर हम हमारे किसानों को दुनिया को संकट से
Start.
हमारे चंद्रयान में
ముందు లక్కీ పాప తినాలా అంతా
Tanvi, who all are answering today? One is Rupam.
We start.
Who is answering? I just want to find out.
Rupam or
Tanvi, who else is answering?
Waghela and Paras.
Rupam, Waghela and Paras, correct?
Yes, sir.
Okay. All three have joined?
Yes, sir.
So today Rupam and Paras is there. Waghela has not yet joined. Let us see. If Waghela has joined, please tell us.
Padima.
फोन अभी गए थे
B222 is Dr. Jay Waghela. So please unmute him.
Okay, I think now we should start. At least two people are there to answer. Brijesh, you can start.
Yes, sir. 82-year-old male sports teacher presented with a complaint of painless hematuria since 10 days.
So this time we are not going too much in detailed history. Brijesh, he will tell us everything about this patient, and then one of you can, if anything he has missed, you can ask. Okay, Brijesh, go ahead.
Okay, sir. The patient was relatively asymptomatic for 10 days and noticed blood in the urine, sudden in onset, painless, non-progressive and self-limiting. So hematuria was complete, intermittent type and associated with passage of amorphous. One P score is given. There was no dysuria, no lithuria, no colicky pain at the time of hematuria, no instrumentation or catheterization, no abdominal pain, vomiting, no backache, no bony pain, no bleeding disorders, no blood transfusion, no radiation or chemotherapy. He was no hypertension, no diabetes, nothing. He was faced with benign prostatic hyperplasia and he was on treatment, tablet silodosin, 8 milligrams since 2 years. Family history was insignificant. There was no any addiction, non alcoholic, non smoker. So in general examination, his blood pressure was 106 by 80. There was no any pallor, icterus, cyanosis, clubbing, lymphedema, no edema, head to stroke. Final examination was grossly normal.
Okay, now this is up to general examination. Anyone of you want to ask any question?
Sir, was there any family history of malignancies in the?
No, nothing.
Paras, you are also there.
Yes.
So you want to ask anything? Or Vaghela, you want to ask anything or we go ahead?
No, sir.
Okay, fine. Go ahead. Vijay.
Yeah. Abdominal examination was normal. Palpation, purpose, auscultations, everything was normal. His prostate was enlarged. It was forming considerably smooth surface, not at a rectal mucus or mobile. But it was grade 2 prostatic enlargement on clinical DRE.
There are continuous noises with Vaibhav. Can you please switch off your mic?
Okay, go ahead.
Investigations.
Yeah, no, let them see. You have gone up to this. So, Vaibhav, what is your clinical impression now? Hello, Vaibhav, I think he has muted himself. Paras, what is your clinical impression?
Sir, 82-year-old male presenting with painless hematuria. So mostly the pathology lies in the lower urinary tract. So it can be a bladder growth or a bleeding can be from prostate, whether benign or malignant.
Yeah, Rupam, you want to say anything?
Sir, it's okay, sir. Hematuria of 10 days, maybe because of benign prostatic hyperplasia or maybe related to any malignancy, sir.
No, but what type of malignancy you are suspecting? Prostate
Sir,
malignancy, bladder malignancy, upper tract malignancy.
Sir,
What is the
till this
commonest?
point,
You tell me in the commonest way, what are your means in the OPD when you are sitting and such a patient comes, what are the commonest things that come in your mind and you have seen it in last 3 years?
yeah, sir, it may be because of urinary tract infections and also due to BPS and also any malignancies in the bladder as well as upper tract, sir.
What is the commonest you have seen with the painless hematuria?
Sir, it is most towards CA bladder, sir.
So one is CA bladder. Then after that, which other thing you have seen more commonly in your practice? In whatever
Sir, bladder
patients you
calculi
have
also
seen.
presents. Bladder calculi also present with hematuria, sir.
Painless hematuria?
No, sir. It is associated
Rarely.
with,
Of course, yes. Sometimes I have seen patients come only with hematuria. They come only with hematuria and then we find out it is there. Then last time also we said it can be enlarged prostate hypertrophy.
yes, sir.
Correct? Median lobe. That will give
Yeah.
rise to and the upper tract malignancy. correct?
Yes, sir.
So now what you want to do? Up to examination, this is over. Now next, what you want to do?
Sir, we'll proceed ahead with the investigations. So first I will do the ancillary investigations of complete blood count and renal profile, and also the routine examination of urine, sir.
Anything else?
If the routine examination of urine shows any the parcels above 5, then we can go for urine culture also, as well as we will advise an ultrasonography examination, sir.
So if you are suspecting hematuria and you are one of your prime this thing diagnosis, differential diagnosis is CA bladder or upper tract malignancy, you don't want to do any other investigation.
Urine cytology also we can advise.
And when he has got LUTS also, lower tract symptom, you don't want to evaluate that.
Sir, uroflow, yes, sir, uroflow.
He is 82 years old.
And yeah, he is on alpha blocker since 2 years.
So you want to do any investigation for that?
Sir, first I would like to see all these investigations, then I will decide to proceed ahead with any other.
Okay. Brijesh, show them.
This is urine routine. Urine routine had pus cells 15 to 20 per high power. So we did a urine CS. Urine CS didn't show any culture. Good.
Yeah, go ahead.
Cytology also we did. Cytology, there was no malignant cells detected.
So how do you interpret that? Urine routine microscopy says 15 to 20 cells and culture sensitivity says no colonies grown.
Sir, RBCs are innumerable.
I was asking about pus cells.
Sir, maybe the patient is on antibiotic. At that time, we'll get a sterile pyuria, or maybe in a case of tuberculosis, genitourinary tuberculosis, we'll get a sterile pyuria. Sir. But till in the history, there was no mention about any medication.
No mention of antibiotics. And other
yes,
thing you said TB. There is no history of TB also. I think people should keep their mics mute if somebody else is talking in the background.
Those who are not answering, please unmute yourself.
Yeah, mute yourself.
Please mute yourself. Sorry. Okay.
So Gaurang Shah sir, उसका आप जरा explanation दे दो ना.
किसका?
वो urine routine showing pus cells 15 to 20 and no.
Yeah, see the first thing is but WBC, there is a difference between WBC and the pus cells. So many a times you know that is why urine routine, even though it is the cheapest test available on the earth, it gives lots of information. And many a time, number one, it can be not collected properly. So then also you may get some pus cells. Second thing is, as you said, the patient may be on antibiotic. He might have taken antibiotics earlier, and that is why you are getting pus cells, but culture and sensitivity is negative. Third thing, as you said very rightly, sterile pyuria in cases of tuberculosis. Fourth, it can be not an infection, it is an inflammation. Okay. So now whenever there is a blood is not only RBC. If there is a bleeding from the growth, there is not only RBC, it is a blood. Blood contains everything. It contains WBC also. No? So that is why you may not grow any bacteria, or culture may not be positive.
Okay.
Fine. So other investigation.
I think Mahendra joined. You might need to make him a co-host. Okay, next, what will you do?
Sir, here the PSA is below 4, so it's normal, 2.1 only. And total count is 11,350. That's also not in the higher side. and creatine is normal. So we'd like to see the ultrasonography reports.
Brijesh, show them ultrasonography report. Show it properly. Make it little bigger if you can.
Yes, sir. I'll try.
थोड़ा quick answer करो please.
Yeah, please, फटाफट.
अभी इस
Paras,
पे
you are also there, and
मतलब
Jadhav is also there, na? Who is
ultrasounds are
there?
seen in urology OPDs day in and out. So I don't think
This is the ultrasonography static film showing liver, spleen, and kidney are normal. In the right hand side, the third column, we can see enlarged prostate. In the left hand side, lower column, there is a large growth seen over the left lateral and posterior lateral wall.
Okay. Just explain, say properly whether what is the, if it is a given, then say the size of the growth, then the size, then there is only solitary growth, then whether it is
There is
appearing.
a large broad-based sessile growth seen over the left lateral and posterior lateral wall of the bladder.
Okay, fine. Okay, Vaghela, now
Can you
next
tell
what?
me,
Yeah, Mahendra, go ahead.
can you tell which is right and left wall of the bladder? And you can see the tumor. You very confidently you said, na? Sessile mass on the lateral wall and sonography, which wall is left and right?
So in the left last column, sir, it is showing
Left में
sagittal view, so उसमें left.
उसमें कहीं मेंशन है क्या USG की in the USG film left wall right wall?
No, sir.
Or you just read the report?
No.
So better you sit with your sonologist and just learn if it is there, because I don't know, this is the last one, is it left or right? I don't know.
Left है ना वो अरे वो sagittal view में तो left right पता नहीं चलेगा.
Just like kidney, in kidney you cannot differentiate right or left until it is written over the right and left kidney. So be careful. What are you saying in the exam?
So right and left of the kidney, you can say only if there is a liver. If you can see the liver, and then you can say, mention about that.
or if
Usually
it
if
is
it is
labeled.
written, yeah.
But in the given film of the kidney, the third one, is it not show right and left? Okay, go ahead.
Report दिखाओ.
Report दिखाओ. Important features, just read, Bridges.
Yes. The bladder is well distended. There is a broad-based lesion over the left posterior lateral wall with 4.5 cross 4.1 cross 2.9 centimeters suggestive of bladder carcinoma. Post-void residue is 29 ml. Also, there is grade 3 prostatic hypertrophy and prostate is approximately 79.9 grams.
Okay, the one who are presenting, what will you do next?
Vaghela, you are not answering. You can please join us. Huh?
Yes, sir.
Yeah, tell us now next what you want to do.
Sir, we can do CT scan to evaluate the extension.
Okay, you have done a plain CT KUB. Tell me, what is the finding?
You want to do plain CT KUB?
Sir, I do not know whether it will be the plain or contrast, but just to see
Okay,
what
if you don't know if it is plain or contrast, so don't answer, please. The next person, please answer. These are some basic things we have been discussing even in the last lecture.
Yeah. So Paras, what you want to do?
I would like to do a contrast in CT abdomen and pelvis.
And why not the
Okay.
delayed phase? Why not the whatever phases?
With with urograph.
Yeah, you should mention that, no?
Yes.
Why you want to do urography? Why you want to stress on urography?
Please answer.
Paras, what information you will get?
Sir, if we see a CT,
Tell us.
yeah, sir, if we do a CT urogram, we can see the functioning of the kidney as well as any there is dilatation of the pelvic calyxal system along with the ureter or any filling defect in the ureter, suggesting of any growth. And
Correct.
also we can see in the delayed phase the bladder if it is full, any filling defect in the, and we can also appreciate any multiple growths or any appearance of the tumors as well.
Okay. You can even probably
Even see cycles spread or anything also.
in some tumors you will see the depth of the tumor.
Yeah.
Okay. Spread where? Spread where?
Yes, sir. Sir,
Spread where?
extra vesicles
Okay. Extravesical spread
and sir lymph nodes infiltrations.
so you can even see the para-aortic areas and the retroperitoneal nodes, no?
Yes.
If you're telling us what you will see, say everything then.
Okay.
You're right. Keep on talking. Don't be silent.
Keep on talking. We don't want this.
In these clinics, we want you to learn to talk only, nothing else.
Sir, the regional lymph nodes also we can appreciate that is the
Regional lymph
external
nodes,
and internal.
the non-regional lymph nodes also in the retroperitoneum. You can see the liver,
Yes.
right?
Okay. So
Okay.
now suppose as an examiner I
spleen.
say, listen, as an examiner I say I don't want to do CT scan. Why should I do CT scan? Let me prove the diagnosis. First I will do the cystoscopy and resection of the tumor and send it for the biopsy. I want to do only biopsy and I want to do MRI. You want to justify your
But
CT
yes,
scan.
sir,
Can you
the tumor
justify?
is a very large tumor. Yes, sir, this tumor is a very large tumor with broad base. So it may have extensive spread and locally advanced. So we would like to know about the upper tract. Any synchronous growth is also there.
Fine. So
But
Nick,
what
I
are
am telling you,
what are the pros or cons of doing the imaging before or after the TURBT?
Sir, if after TURBT, even CT also cannot appreciate bladder wall invasions and perivascular invasions.
Bladder wall, nahi. If you want to be specific, you say bladder muscle.
Muscle, sir.
See, basically any surgical procedure alters the anatomy.
Sir has asked you pros and cons. You went straight away to one point. When question is asked like that, you have the advantage. No? What are the indications of doing CT prior? Tell that. No?
Advantages, sir, I already spoke about that any synchronous growth is there.
Okay.
And if there is any advance, then change the plan of management.
Is there any disadvantage of doing the imaging prior?
Real function, and then we can decide if we directly go for CT run. It will be disadvantage for patient not knowing the renal profile.
I didn't understand that. Sorry.
is there any advantage of doing
And sir,
MRI
also-
in this patient?
Yes, sir. MRI also you can go to see the muscle invasion is there.
Okay. Ganesh, you ask. Mahendra, you want to ask? Just complete your question.
See, if you are not doing a CT, going ahead with a cystoscopy evaluation and a TURBT upfront, then post procedure for such a big tumor like above 3 centimeters, Then post-procedure, if you need to do a CT, you will have to wait at least 3 to 3.5 weeks before all the reaction settles down. And even in that case, many times there are reactive lymph nodes which look as enlarged lymph nodes in the maybe ipsilateral side, you know.
Yes,
So above 3 centimeters, it is always safe and clear to answer about doing an imaging prior. Even sometimes below 3 centimeters, whenever your patient presents with a hematuria, you can easily ask rightfully a CT IV.
yes.
So
Okay,
this is
then
the
what?
way you are going to answer in exam if the examiner asks you. Okay, you have to justify. Fine. Okay.
Many times
So
the
now,
post-URBT CT shows the bladder wall thickening and perivesical fat stranding. Sometimes these are the features of a extension of disease to the perivesical area. So you are confused, and that is why the imaging should by priority done beforehand. MRI, as sir asked you, is a very good investigation. For exam purpose, I think right now, let us say that it is still evolving. It is a very good investigation, gives a very good anatomical resolution, and probably in future it may help us decide whether something is T1 or T2.
so this, please, you all of you write down whatever Dr. Ganesh has said. Exactly the same wording use it when the examiner asks you in
Yeah,
exam.
because I didn't say ki we should do MRI technically, because right now CECT is still considered the best.
So answer exactly what he has told you. Please write down, all of you.
Okay,
Okay.
so CT scan
Fine.
hai.
Acha, what about the prostate size? Prostate is also big. Patient has got LUT. None of you want to do any investigation for prostate.
Sir, but PSA is too.
Yeah, okay, but you don't want to. He is on already on an alpha blocker.
Is soon.
Okay, so ask for uroplometry. Please just
Sir,
show them full
we'll evaluate
uroplometry
you.
and then show them CT scan.
When sir is telling patient has got LUTs and don't you want to think about prostate, you're talking about PSA. You're just digging your grave in the exam. Can it not just be a benign enlargement of prostate? Why you are talking about PSA?
Sorry, sir.
Paras, can you just comment on uroplometry? You want to do anything else after that?
The voided volume is 160, which is educate. The Qmax is slightly it's lower than 15, and the average is also less than half. So it's a poor flow.
Okay, so you will keep it in mind. Okay, you have to treat his LUTs also. Okay, go ahead with the CT scan. We just show them all the three films again, and then we will ask them.
Yes, sir.
So you are ready?
Yes, sir.
Okay, answer. Say, tell us how you are finding. Paras, can you just say?
So this is a CCT abdomen pelvis with a urography. In this the film, we can on the top we can see a enhancing lesion on the right on the left lateral and posterior lateral wall of the bladder. Size is mentioned, but we cannot read. The prostate is also enlarged. In the lower film, we can see the excretory phase with a filling defect, and there is mild fullness of left PCS. But I cannot see any extravesical fat stranding or extravesical invasion. And rest of the bladder wall thickness is normal.
Okay, Bridges, read the report.
The urinary bladder is well distant and reveals a uniform enhancing mass lesion arising from left posterior lateral walls, showing few peripheral calcifications. Approximately measures 4.7 cross 2.0 cross 4.7 centimeter. There is no obvious extension of soft tissue mass into the perivesical pharynx. The left vesico-ureteric junction appears to be in close proximity and just posterior to the lesion, without any obvious involvement or proximal ipsilateral hydroureter nephrosis. No evidence of significant abdominal pelvic lymphadenopathy. Prostate is enlarged with 74 cc volume.
Now this is the finding. Now what you want to do? Quickly, you should be prepared.
Sir, we'll go for a cystoscopy, sir. Cystoscopy with TURBT.
Okay. Along with that, you will. The question is, which type of anesthesia you like to give, and give your reason.
Sir, we should ideally go for general anesthesia. If we give spinal anesthesia, then we have to give operator block. So the anesthesia of choice is always general anesthesia in TURBT, sir.
So in general anesthesia, you will not get obturator drug.
Sir, less.
So general anesthesia with a muscle relaxation, still there are some chances, and you may have to give block. So
Yes,
that is one thing. Second thing, now if you are getting the drug, how will you manipulate?
sir, we should ideally use a bipolar current, and we should while cutting the tumor, we should cut in.
Okay, I want to ask you one question. When you are doing TURBT and when you are doing TURP, what is the difference? Means usually people say something about the loop. What they say about the loop? Which type of loop you will use in TURBT? Which type of loop you will use in TURP?
Sir, thin loop we should use for TURBT, sir. Thin
And
cutting.
have you seen this thing bipolar loop?
Yeah, bipolar loop, and also laser also we can use, sir.
Yeah, but bipolar loop you have seen, it is thin or it is thick?
Bipolar loop is sir, thick, sir.
Then, so when you go down, initially it is okay, but when you want to go to the muscle, it may become little difficult. Okay, now the patient is getting jerked.
Yes.
How will you manipulate? Paras, you can answer. Paras.
So we can use a continuous irrigation. We should not over distend the bladder. We should use small burst of current. We should cut the tumor in piecemeal and not en bloc. We can also use laser.
Okay. And very rarely, if you want, if it is really troublesome, sometimes you might have to use coagulation. You know, that also will help you. Of course, you may not get you may get little charring, but you will be able to at least resect the tumor.
One of the most important thing you forgot was you can always give an obturator block.
Yeah. So that we discussed in the beginning. Na? He said that in general anesthesia, otherwise we have to give obturator block. But Ganesh, do you regularly give obturator block when you are doing TURBT or means in this cases?
Not regularly, but sometimes you can give a block. Like if the tumor is just sitting on some specific area, it makes life very simple.
And usually it is given by the anesthetic, or we have to give, because I have never given.
Anesthetist gives, you can also give. Mahendra is expert in giving.
Mahendra, can you just teach them how
Mahendra
to give?
will explain you how to give.
Please.
Mahendra.
Where is Mahendra? Mahendra?
I think उसको अगली बार बताने को बोलते हैं.
No, he can, after some time also he can say, let us, okay, fine. Bridget, show them the histopath report.
Histopathology report.
Anyway, Bridget, before that, I want to ask them, what is the role of mitomycin in this case? Whether you like to give or you don't want to give?
Sir, this seems like it is a T1, so we'll go for some mitomycin, sir. If the tumor is muscle invasive or high grade, then we don't high grade. Obviously, we know not know. Then we can omit mitomycin, sir.
Ganesh, what is your say on this?
How will you see grade on the cystoscopy?
No, sir. If it is not muscle,
when you are answering, answer and use word properly. If I find that the tumor is absolutely broad based, looking morphologically like an invasive tumor, not high grade वगैरह, then you may not give. But if you are in doubt, you can err on the side of giving. You can give it when you have a 4 centimeter large papillary tumor. It may be the small chance of being muscle invasive, but I might err on the side of giving mitomycin. If I find the tumor overtly going into the muscle during TURBT, sometimes you can see the detrusor fibers and clearly the muscle, it goes in the muscle. We would not give. If you have created micro perforations more than 1-2 number, you will not give. If it is bleeding badly or something, you will again not give.
Yes.
I think proceed.
So
somebody needs to answer what is the benefit of giving this intravesical mitomycin. And another question is, if mitomycin is not available in the store, which other drugs can be given?
Sir, it reduces the recurrence rate, sir. If we give mitomycin within 6 hours of surgery, post-operative.
This is like I ask you a question: how do you go from Mumbai to Colombo? So you can go by aeroplane, you can go by train, or you can go by boat. So I have to answer like, if I take a plane, I will reach in 2 hours. If I take a boat, I'll reach in 27 hours. Like that.
Sir, sometimes after doing TURBT, there are chances of tumor seeding. So that can be prevented if we give mitomycin immediately in the post-op period.
So how will you give mitomycin? First of all, say how you will give mitomycin and then say.
Yeah, sir, we'll give 40 milligram of first we'll reconstitute 40 milligram of mitomycin with 50 ml normal saline, and then there is always a 3-way catheter that we place post TURBT. So we'll stop the irrigation and we'll instill the 50 ml normal saline that is reconstituted with mitomycin, and Then we'll, sir, with gravity drainage, we'll put the mitomycin inside the bladder and we'll clamp the catheter for, sir, 1 hour. And then after that, we can, after the 1 hour period is complete, then we can declamp the catheter and we can start the irrigation. Before that, sir, we should be careful that there should not be any hematuria. And obviously, bladder perforation also, we cannot give mitomycin.
Okay, now answer other questions Dr. Ganesh Bakshi has asked. So if mitomycin is not available, what will you do?
So
Oh,
we can
sir, we can give
epirubicin also. Even the irrigation fluid which we use also wash away the floating cell. So irrigation also helps to prevent reimplantation.
Ganesh, you want to add anything to them?
Relative risk reduction of 35% to 40%
What is that?
in the recurrence. So that should be remembered.
Yes, sir.
Absolute risk reduction, I think, is 9 or 10, 9 to 11%. Remaining things you answered. This is the most important thing. Tumor seeding vagere is the mechanism. Okay.
Yes.
Okay. Just show the report.
Was low-grade urological carcinoma, no lamina propria invasion, deep muscles, infrared biopsy were not involved by the tumor.
Someone has asked about the BCG intravesical at the time of surgery.
I think we should start a habit of putting who is asking. We should know some names.
Sir, absolutely contraindicated, sir.
Who is the DR? Please, can you put your name? Because immediate intravesical BCG is never put.
इतने चूते लोग कैसे हो सकते हैं? सोच लाइव अटेन्यूएटेड वैक्सीन है बीसीजी तो टीआरबीटी की है मतलब 10 तेरे सरफेस इज रॉ है बीसीजी
Okay. This is the report. Now what you want to do? Vaibhav. Paras. Please answer what you want to do next now.
I have an observation with this batch. You are taking some time to interact with us. We are here to learn. Make blunders but talk.
Sir, this is a low-grade urological carcinoma. So there is no role of BCG in the follow-up as well as any other treatment. So we'll ask the patient for follow-up at three months for cystoscopy, sir.
So Paras, what is your say?
Similar, sir, low grade. But sir, there are according to AUA, sir, it will fall in a intermediate category. But according to EAU, if we follow, then it will fall in high risk because patient is more than 70 years and the 3 centimeter more than 3 centimeter mass.
More than 3 centimeters.
So what you will do? Whether you will give BCG or you will not give BCG?
Sir, I would like to give.
Sir.
You will like to give or you will not like to give? Paras, what is your say? You want to give BCG or you don't want to give BCG? Vaibhav? Who is there?
No,
Vaibhav,
sir,
na?
no, sir. I don't want to give BCG, sir. It's a low grade. BCG will be for high grade.
Aren't you surprised that such a big mass and it is coming as a low grade? You want to do anything to that? You want to take a second opinion, or you want to do re-TUBR, just like re-TURBT? Is there any role of?
Sir, we do read URBT if there is not
Then lower
muscle is not
there is
present.
no role for RETUR.
And if the tumor histopathology report shows T1, then you can go for. But it shows low grade, not high grade.
Ganesh, can you just tell them what to answer in exam?
See, standard answer is I will risk stratify the patient. So part of that somebody answered. So what is low risk as per EUA? Primary, single, TA, okay, G1, tumor less than 3 centimeter in diameter without CIS in a patient less than 70. So that half the thing somebody said was right. Or a primary TA, LG, G1 tumor without CIS with at the most one of the additional critical risk factors which is down. Now, high risk. So high risk is all T1 high grade or stroke G3, correct? Without CIS, that is the first criterion. Except those in the high risk. So high risk is age 70, multiple tumors and tumor diameter more than 3 centimeter. And the second criteria with high risk is if this is low grade tumor, let me just read to you what is low grade. So when you put a low grade tumor into high risk criteria, it is compulsory by EAU that you need all the 3 risk factors. Okay. So 70 and more than 3. But there are no multiple tumors in this case. So this tumor is classified as intermediate risk as per AUA as well as EAU. Now what to give? You have already probably given intravesical mitomycin immediate. Intermediate risk, we have either a choice of intravesical BCG with a induction and maintenance up to 1 year in the SWAP protocol. Or we have a mitomycin, which again can be given intravesical with induction plus maintenance. That is it.
Understood? So whatever you answer, you justify it. This, see, every case is different. So in this case, we have given intravesical BCG and we have followed up the patient. Okay?
What
Vijay?
sir did was that what Ganesh sir did was to put those criteria into the risk categories. So that is what you all should have done. You all told about the risk factors, but you have to put it in that and then assess that where it falls. So I think it's clear now.
Easy definition of risk stratification is of low grade and high grade.
Correct.
Sorry, low risk and high risk. Whatever comes in between is all intermediate risk.
Very well, he has explained it. Now we are clear. So next time when we discuss, then you should tell like this risk strategy.
Next.
Vijay, just show them.
Yes. To check cystoscopy on 9th month, there was a growth around prostatic urethra. So we did a biopsy and we sent for histopathology reports. So histopathology report has been shown.
So what does it say?
Brijesh,
Yes, sir.
just read it now.
Yeah.
What is the report?
One of the two bits of prostatic tissue shows an acinar adenocarcinoma with lesions 3+3, and tumor has involved approximately 10% of the tissue. There is an absence of basal cell layer in the atypical small acina has been confirmed with negative staining. ACI does not express any AMKCI. However, they express PSA and NKX 3.1.
So what is the diagnosis you got?
Anyone from the group can also answer. If you want to join, any one of you want to join. Yeah, tell me. Vaibhav, just don't worry. So now he is a 82 years old male who is an athlete. Actually, he is a teacher. He is a PT teacher in one of the schools. Even at the age of 82, he has got no other comorbidity, right? He is absolutely fit. Second thing is he has got a CA bladder, which is non-invasive, muscle invasive. You already given BCG. Check cystoscopy 3 times done. Every time there is negative, multiple biopsies, no CIC. But now he has got this report. He is sitting in front of you and he's asking me, doctor, now what? Paras, you answer.
I will like I would like to evaluate, sir, by doing MRI.
You want to do MRI?
Yes.
Okay. So you want to do MRI for what?
So it's a Gleason 6 acinar adenocarcinoma. If it is like localized tumor only, then we can plan as per that.
So consider that it is localized. What will you plan?
For Gleason 6, we can
MRI
plan for
done. MRI says findings are PIRADS 2. PSA was 2.1, if I mistake not.
Oh, yes.
Yeah, that time it
That takes the PSA density very low.
Sir also told you he is 82-year-old.
He is 82-year-old.
Yes, sir. We'll do a
So-
wakeful watch, sir. And life expectancy.
Waitful watch,
Yes, sir.
watchful waiting.
Yes, sir. Watchful tip.
So what is
Active
active
surveillance.
surveillance and what is the
Watchful waiting.
waitful watching or watchful waiting? Tell me the difference. Paras,
Yes,
tell me
sir.
the
Active.
difference. Yeah, told me. Bye, you can also tell me.
Yes.
Somebody please mute your mic. So many times you have told. Somebody's talking in your background. Please mute your mics. I think we should have the standard protocol in these clinics.
Yeah. Mute everyone else. Yeah, Vaibhav, come on, go ahead.
In active, if we can repeat the serum PSA and DRE, sir, and if any active means rising serum PSA or DRE is showing.
Who is answering this, Vaibhav?
Yes, sir, Vaibhav, sir.
See, whenever you answer, still somebody has not muted the mic. Who is that? Can somebody identify the person and name him?
Yeah, I think Brijesh was there. Okay, go ahead.
So if you are going to give a general answer that I will do DRE, I will do something biopsy, what is the point in appearing for the exam? If you think And no patient will also like you. This patient will come to you once in your OPD and then say कि doctor बहुत randomly बात करता है. He'll go to the next best doctor around you. So whenever you talk about any kind of active surveillance protocol, it should be very clear what is the protocol. What we were probably thinking at the age of 82 was a watchful waiting. In some words, in the PROTECT trial, it was labeled as active monitoring, loosely active surveillance. And watchful waiting per se is that you don't do anything. You tell the patient that the PSA seems to be this much. There is a diagnosis of prostate cancer, which looks to be early as per the biopsy grade. And probably this cancer will never kill you. It might slowly increase. It looks indolent. And you don't need any test. That is watchful waiting.
Okay.
On the contrary, active surveillance needs a protocol. It needs an active observation. It needs SOS active tests, and it needs SOS and active decision whether this patient needs to be converted from active surveillance to active treatment arm, which may be either radiation or surgery. So I hope it's clear with everybody.
Yes.
Understood?
Yes.
A simple
Yes, yes.
example is if this patient is very young, okay, you will put him into active surveillance. That means you will, anytime you find that it is progressing, you may go ahead and can do radical prostatectomy.
Prostate.
Means other way means when you're doing watchful waiting means you know that even if tomorrow patient comes to you, says that I have got a backache, I have got a pain, or I got any other problem, you will not do any investigation to find out whether there is any metastasis or not. You will not keep on doing repeated PSA. You will not do it his MRI. Maximum what you will do is give him, if he has got a pain, you will give him medicine for that. If he has got lurch, you will give medicine for that. Understood?
Yes.
Okay. So now you tell me in this
Okay.
patient what you want to do. Paras, what you will do? This patient has come to you. He is asking you, sir, I have got a PA bladder. Am I cured? Last 3 cystoscopy you have done and it is showing negative. I have no growth. But instead, you have done my PSA which is 15. Brijesh, show them the new PSA. So he has got a PSA, new PSA which we did. Probably it may be because of, I don't know, we have done after the QRBT or we have done before that. I'm not sure. But it was showing 15 and
15, yes,
this is
15, sir.
50. So now you got, Paras, what you'll tell him? What you'll tell him about bladder and what you'll tell him about prostate?
So for prostate, I will do watchful waiting, sir. Patient is 82 years old. With, life expectancy is less than 10 years. And for even in the intermediate group, at least 5 years of surveillance in bladder tumor is required. So since we have got this in 9th month cystoscopy, so for prostate, I will do watchful waiting.
So now for the bladder, how will you follow?
So for intermediate group, sir, first year we do cystoscopy every 3 monthly. Then for the next 2 years we do semi-annually. We also do urine cytology. We do a CT scan annually for 2 years, and for the next further years, if there is hematuria, then we'll do. After 2 years, if there is no growth, recurrence, or hematuria, then no CT scan imaging is required.
Okay. So now He is 82 years old. 1 year has passed. After 83, 2 years are over. You have done chest cystoscopy. Everything is fine. His PSA is increasing. Now 15 to it has become 20. Or you don't want to do anything, correct?
Yes, sir.
So you will not do repeat PSA also in this case. But suppose I don't believe. Patient says that I am afraid. I don't want to live with a phobia that I have got a cancer in my body. Now you are doing chest cystoscopy to find out about the CA bladder. Same way, I will like to do some investigation for my prostate. So what you will suggest? Yeah, Vaibhav.
Sir, how is his LUTS symptoms along with that? Whether he is having developed a poor flow because of this or not? That I would like to know, sir.
Okay, after 2 years, his flow has decreased. Now what you want to do?
Along with cystoscopy, if his symptoms are LUTS are very poor flow, then we can plan for some channel TRP for him. And at the same time, we can plan for orchidectomy also. We can offer him orchidectomy.
Suppose this patient has said, I want to get a treatment, some treatment for my prostate. Will you offer him orchidectomy or will you offer him injection, LHRH, agonist?
Yes, sir, both are the options. We can offer him the hormonal injections as well.
Paras, what is your say?
Mainly, sir, I will do watchful waiting. So we'll explain the patient regarding the progression of the disease, sir.
Okay.
If the mostly the disease is slow growing, and if the life expectancy is less than 10 years, sir, then nothing to do for it.
Ganesh, there are different scenarios. Can you just guide us? Now, this patient is 82 years old, and if he says he is an athlete, it means he is walking every day 4 to 5 kilometers. He is a teacher, PT teacher, is regularly getting up at 6 o'clock, going to the school, teaching students, walking around, everything. He is otherwise absolutely fit. You cannot.
Yeah.
So, in such patient, how will you explain him?
सर मुझे वो क्वेश्चन नहीं समझा. I just want to get a charger actually.
No, the thing is, this patient now, everyone is saying watchful waiting. Okay. But he is an athlete. He is otherwise fit, no comorbidity. And he has got a CA prostate. So whether we should go ahead and give him one LHRH agonist injection or not to give anything, number one. Number two, whether we should do any further investigation because he is very apprehensive. He doesn't want to, he says that, doctor, you do whatever is best for me. But I don't want to live in that, threat that my cancer will spread or anything. Otherwise, I'm fit. So in that case, still we will do WW or we will do some investigation.
It depends, sir. मतलब how much is the expected estimated life expectancy?
Yeah, in this case, I think up to 1992, he will definitely survive. If not considering CA bladder, otherwise he's absolutely fit.
Then with these prostatic biopsies, we would do an MRI after some time. Assess technically what is how it looks, what pilot scoring is given in the peripheral areas. 10 years is a fair amount of time where you can offer option to the patient about giving therapy, either may offer radiation first, considering his age.
So TURP and radiation, if he has got symptoms of obstruction.
We can do that.
Okay.
That would be, and if patient insists, then the second option would be radical prostatectomy.
Yeah. But that will be after how many years? Because patient has got CA bladder also. So can we do radical prostatectomy in 1 or 2 years, or we should wait for 3 to 4 years?
So there is no guideline like that.
No guideline. So you do
Whatever
radical
you do,
prostatectomy. Suppose he's a young patient.
whenever there is a double malignancy, you will have to counsel the patient in a customized kind of way. You will have to tell him about both. This is intermediate risk but low grade. The chances of progression and recurrence with a intermediate risk but low grade tumor. That you will have to explain. So overall thinking, if this bladder cancer progresses and if he's going to live 10 years, then a radical cystoprostatectomy is the best thing.
Okay, even if it is a low grade.
We are having low grade tumors only. And if the prostate is also like 3+3 and the peripheral zone does not actually have any great suspicion, sometimes what you can do is you can do a biopsy of the peripheral zone.
Okay.
What you find in that. If sometimes you find that only 1 or 2 cores would have 3+3 6, the distinct guideline today in Western countries everywhere is 3+3 6 can just go for active surveillance. Now I'm changing here from to active surveillance, considering that this patient is going to live for more than 10 years.
Okay.
That So then you go and follow him up in the active surveillance protocol. That's okay.
Okay.
3+3 6 really takes a long time to progress.
So anytime have you come across like a patient is 55 or 60 years old, or this thing, primarily he came to you for CA prostate, but at the same time when he investigated him, and you found out that there is even coexistence of CA bladder.
So we have always found reverse actually. CA bladders, we have sometimes found CA muscle. That has a standard incidence waiting.
Okay.
Now, depending on all these customized counseling, but I don't remember doing radical.
So have you
many times usually the one found prostate cancer found along with bladder cancer is usually quite low risk and the reason is usually
okay. So now what is the final answer that they should give in this exam in this patient?
Sir, I think exam में ऐसे 2 malignancy का patient कोई रखेगा
नहीं रखेगा ना? Okay.
If a student needs to answer this question, means he has gone beyond his distinction. It depends on management of the cancer will happen. Bladder का तो मैंने बोला, intermediate, low grade, whatever happens to the patient. About prostate cancer, and to consider in age of 70. In age of 70, I might initially offer radiation because later on, if bladder cancer is aggressive, but bladder cancer, whatever, it becomes muscle invasive. I would need to operate the patient that time. I would prostatectomy.
Oh, okay. Fine.
If I have a T1 high grade tumor, which is size 4 centimeters, with an established prostate cancer, the time when I might explain the patient in a different way. I might tell the patient, you have 2 cancers. You are 70-year-old. You get operated for the prostate. Your T1 high grade, that is correct?
Correct.
T1 high grade is a very dirty tumor. It can always have a high progression rate as well as a recurrence rate. In that case, You get cured with both the cancers.
Fine.
There is no book answer. It will be a customized answer.
Yeah, so every patient is customized, is a different
This
entity
particular
altogether.
setting, double malignancy, age 82 will be a customized
Yeah.
answer.
Correct. Fine. So, any other questions you want to ask in this? Okay, the one question is, when you will do re-TURBT? And when? After how many days you will plan?
But what is the need for re-TURBT? That also you.
Yeah. Come on, Paras, answer fast.
For re-TURBT, if uh, we have left some tumor inside, or if there is no muscle in the biopsy, or if we have to restage the in case of high risk group.
High risk or high grade?
High grade.
So you think that you're not
Suppose
resected
suppose if it is a TA high grade, I have done a TURBT with lamina propria negative and muscle also there and negative. Then
So in sir, TA high grade, sir, we can consider there is a chance of 5 to 15% upstaging.
Only that much?
Sir, TA high grade. In T1, sir, there is 30% chance of upstaging.
30%. If
so, if
see,
it is T1,
where have you read all these statistics from? What is the reference?
so Campbell.
तो कैम्बेल में रेफरेंस किसका दिया है? Because you are quoting wrong. That's why I'm asking you. Reference किसका दिया है कैम्बेल में? कैम्बेल पढ़ते पढ़ते थोड़े references भी पढ़ो, उसमें लिखे रहते. There is a different statistic if the muscle was present in the initial TURBT. There is a different statistic if the muscle is absent in the initial TURBT. Harry Hare का reference है. See, some of the things, some of the references you should know. Don't mention blanketly Campbell. मेरे जैसा examiner आया तो कभी accept ही नहीं करेगा. It straight away means that you read less. It means that you are lazy to read.
So,
Sir, there is a confusion about restaging TURBT and second TURBT, sir. What is the difference?
Who is that?
Sir, Rupam, sir.
So there is no confusion. And I am not going to answer this question because this is sheer laziness. There is no confusion in re-TURBT.
if you're 100% sure that the mass is too big, multiple mass, and you have not resected it, you're going to do re-TURBT. You're going to do re-TURP. You're going to tell them, I will be doing in 2 stages. Understood? Fine.
I think this is a small topic everybody you have an NMIBT somewhere or the other, or you might get an instrument which is a working element, and examiner might just ask you what is re-TURBT concept, when it should be done, like Gaurang sir asked you. You have still not answered him the question and given the answer about when it should be done.
When you will do?
within 6 weeks, sir, after.
So like I have done the TURBT today. So can I do it after 2 days?
No, sir. After waiting for at least 2
No, sir.
weeks.
We will wait for re-epithelialization.
2 weeks, sir. We will wait.
You will wait for what?
Re-epithelialization of the.
अरे स्टैंडर्डली आंसर दो ना, वही कैम्बेल में लिखा है from 2 to 6 weeks. ये
From
क्यों
2 to
ऐड
6
करना है?
weeks,
What is re-epithelialization? Now tell me the theory of re-epithelialization. Please tell me the theory of re-epithelialization. Physiological steps of re-epithelialization.
So an exam, na, Just go, give a standard. Don't deviate yourself. If you deviate yourself, there will be a problem. See,
And
examiner,
sometimes you think you are going to use these great words and create a favor to the examiner. I'll ask you, you tell me the steps of reepithelialization. It's given in Sabiston, third chapter.
Sorry, sir.
अभी Sabiston तुमने पढ़ा नहीं रहेगा. It's general surgery text.
so don't answer such in such way, okay?
Okay, sir.
Give the standard answer. If the examiner asks you, straightforward answer. When you will do it, 2 to 6 weeks. What are the indications? So as Paras has said, you are not happy. You think that you are not removed the full mass. Second thing is the muscle is not involved. Third is it is a high grade. Okay. Then if there are multiple and you want to find out whether carcinoma in situ is there or not, these are indications.
Residual multiple presence of CIS in the first HPR. These are the three most common reasons. And in many institutes, there is a protocol where T1 high grade, you standardly do a TURBT. उसका statistics है in Hers paper, which you read.
Yeah. Fine. Okay. Ganesh, anything else is left last time and this time?
Follow-up protocol हो गया ना?
Follow-up protocol just said ना?
How will you treat a diverticular tumor?
Yeah. So if there is a mass in the diverticulum.
So same 85-year-old person comes with hematuria. You have done a sonography, shows query thickening at the left posterolateral wall. And but that's it. You do a scopy, you see a diverticulum and a tumor which is in the diverticulum. Now, if you want to ask any questions, ask. Or if you don't want to ask questions, you tell the treatment of this condition.
So we will like to do a TURBT, sir. If it show a low grade tumor, then
Diverticulum के अंदर tumor है. I asked you, I gave you an opportunity. You asked me a question.
Diverticular tumor.
Never asked me whether the diverticulum is narrow mouth or wide mouth. The scope will or the TUR element and the TUR whole sheet is 26 French, whether it will go in that diverticulum or not. And even if that 26 French goes in a wide mouth diverticulum, do you know what is the diverticulum and how much is the chance of perforation?
So you want to know whether it is a congenital, means it's a 3-wall diverticulum or it is a secondary to obstruction. So what is the difference between these two?
What are the stages of obstruction causing a diverticulum? वो stages बोलो. वो general urology पूछ रहा हूँ. Sir, है ना ऐसा stages of diverticulum?
Yes, stages means of course the initially
How
when
the
you feel like.
diverticulum is formed? बताइए please, general urology. Please tell.
So what is the first thing you'll see whenever there is obstruction? Paras, what is the first stage?
Everybody will have seen this on a cystoscopy you do for a prior to TURP.
So diverticulations, then sacculation, then diverticulum.
So diverticulum, what happens? Which part is projecting inside? So first there is a hypertrophy of the muscle, correct?
Yes, sir.
And then this circulation takes place where even the part of the muscle is there. But when the diverticulum takes place, only mainly the mucosa. And it's surrounded by serosa, nothing else. Muscle is not there in acquired diverticulum.
Is mucosa which herniates through the detrusor muscle. And there is just extravesical tissue on it. That's it. So there will be extravesical fat as the external layer. So abhi whoever was answering was talking about doing a TURBT.
So if you do TRBT, what will happen?
So if this tumor is at the mouth of the diverticulum and a very small tumor and visually low grade, which is a very absurd statement, sometimes you can try doing a TURBT with great care, otherwise you would form a perforation. If you cannot remove this tumor via any other means, then probably you need something which is called a diverticulectomy. In other words, we will call it a partial cystectomy. And if I do that, I will do a lymph node dissection. I would do a lymph node dissection on that side, because I would consider a diverticular tumor as a kind of a PT3 tumor. Okay.
Yeah.
Now, before I take the decision of doing this diverticulectomy, I will do a proper cystoscopy and check if there is any other tumor there. That is most important. And we should map the diverticulum, how far from the ureteric orifice, whatever is that. I hope these things are clear with you.
Yes, yes.
Remaining
It's a very good. Ganesh,
remaining
it was a
treatment will happen after checking on the actual histopathology report. If diverticular tumor is seen on the external cervical patch, then it is PT3, and we will have to offer treatment to this patient as the PT3. Remember that.
fine.
और कोई
Question, anything? Is there any question in the audience? Anyone wants to ask?
you can ask random questions.
Because now we are finishing CA bladder, non-muscle invasive and even muscle invasive, MIBC. For chemotherapy, we'll call someone else also, onco physician.
Yeah, it would be nice.
Yeah. So any question? Otherwise, we stop our discussion over here. Okay?
Okay.
Okay. Thank you, Ganesh. It was the last one was a real good one. That to do the even the
Just
lymph node
diverticulum, I think,
dissection on the.
so people should understand how to treat that.
Yeah. Correct, correct. And these are the simple thing. If the examiner asks them, these are the things they should know.
And you will not have it in case. You might have a CT scan in your imaging, which you will see as a diverticulum with a mass. The discussion can be
Yeah.
various places these things can come. So you should have a general idea, and I would suggest you that read generation.
Yeah.
But it
So
will
all
be
of them,
to read
yeah,
some books properly.
and the Ganesh, as you said very rightly, whenever there is a reference given in Campbell, they must open up that reference and see.
Yeah, some important things you should know the reference because somebody is going to ask you. In that one
Especially
line,
when you are doing so well, definitely. When you
in
reach
one
to this
line,
level,
if somebody
definitely they
answered
will ask.
about that RETURBT, you are not able to answer any statistics. So, examiner needs to ask you what is the percentage of this, what is the percentage of that. So, unless it is written in answer properly,
Okay, fine.
not
So we
so
end
difficult.
our next time. We'll let you know in 1 or 2 days what topic is there. Okay.
Okay. Good night.
Thank you. Good night. Good night.
Thank you, sir. Good night.
Good night.